Good morning, all of you. First of all, I would like to thank the KSOS Scientific Committee, Dr. Srini sir and Dr. Aisha for giving me this opportunity. Here I am going to talk about who is fit for a refractive surgery. First of all, why should patient opt for refractive surgery? The most common indication is cosmesis. Some people will request for a refractive surgery because of spectacle or contact lens intolerance. Some may ask for an improvement in the unaided visual acuity and some for job recruitment. The fitness for surgery can be divided into three headings. First one is screening and history, then preoperative workup and ancillary test, and the last part is the counseling. Screening, always select patients above 18 years of age because that is the FDA approved age limit. They should be free from ocular comorbidities. They should have a stable prescription for at least 1 year, should not be pregnant or nursing. In the history part, ask about the age, occupation, trauma, hobbies, vision requirement, tobacco and alcohol use. Drug history of steroids, amiodarone, isoretinol and OCP is important. Systemic history of any autoimmune diseases, diabetes, PCOD, immunosuppression, atopy, epilepsy is significant. Always ask about ocular history of trauma, diabetic retinopathy, glaucoma, keratoconus, fuchs, herpes, Sjogren's, dry eye, contact lens use, RD, etc. The absolute contraindication for a refractive surgery include unstable refraction, ectatic conditions of the cornea, significant blepharitis or allergy, exposure keratopathy, uncontrolled glaucoma or uveitis, pregnancy and breastfeeding, single functional eye. Relative contraindications include dry eye syndrome, herpetic infections, diabetes, immunosuppression, autoimmune disorders, propensity to keloid scar formation and epithelial basement membrane dystrophy. Coming to the workup part. Start with the uncorrected visual acuity, best corrected visual acuity and near vision of the patient. Manifest and cycloplegic refraction is compulsory for all the patients. Dominance test can be done with the hole in the card test. Cover test is important because asymptomatic tropia or phoria can become symptomatic after the procedure. Slit lamp examination should look for any infections or inflammation of the lids, conjunctiva, cornea. Also check the pupil and the lens. Fundus evaluation to look for any pathologies in the optic nerve, macula and in the retinal periphery. Pupil size should be measured in bright and dim illumination. IOP and gonioscope is also important. IOP can be raised during suction in the LASIK because of postoperative steroid use, and also false low values are expected after refractive surgery. Tear film analysis is done with Tibet and Shermer. Orbit evaluation is also important because sunken eyes and prominent eyebrows can give rise to difficulty in LASIK. Coming to the ancillary test. Keratometry is important because flat corneas less than 40 increase the risk of free flap and steep corneas more than 48 increase the risk of buttonholing. Excessive flattening or steepening after the procedure can result in poor quality of vision. A steepening of 1 diopter for every diopter of hypermetropy is expected and a flattening of 0.8 diopter for every diopter of myopia is expected. Coming to the corneal topography and tomography, it helps in detecting early and suspected cases of ectasia and also helps in planning topo-guided custom ablation. Eyes with visually significant irregular astigmatism are not generally good candidates for refractive surgery. In the topography map, always look for the elevated points in the anterior and posterior elevation map, whether they are correlating with the highest power in the sagittal map and the thinnest point in the pachymetry map. Special attention should be paid if there is significant posterior corneal elevation or a bad score more than 2 in pentacam. When keratometric and topographic astigmatism is significantly different from the refraction values, refraction should be rechecked. It can be due to lenticular astigmatism or posterior corneal changes. Coming to the pachymetry, this helps to decide the most suitable treatment for the patient, whether it is surface ablation, thin flap LASIK or SMILE. CCT less than 480 microns and RSB less than 280 to 300 microns is considered as a contraindication. Coming to the ectasia risk, percentage of tissue altered is calculated as flap thickness plus ablation depth divided by CCT. So a PTA value of 40 or above is considered as high risk of ectasia. Ectasia risk scoring system by Randleman consists of parameters like topography, RSB, age, CCT and mean refractive spherical equivalent. Points 2 or less is considered as a lower risk of ectasia, 3 for moderate risk and 4 is considered as a high risk of ectasia. Roughly, 1 diopter of ablation removes around 12 microns of stroma. The amount of stromal tissue removed depends upon the optical zone and the magnitude of refractive error. So the ablation depth is equal to diopters of correction into optic zone diameter square divided by 3. Residual stromal bed thickness is important. It is calculated as CCT minus flap thickness plus ablation depth. A minimum of 280 to 300 microns is necessary. Contrast sensitivity can be checked using grating tests like VSTEC and optotype tests like Pellier-Robson chart. Wavefront analysis provides an objective refraction measurement. It is used to refine the manifest refraction. If the manifest refraction and the wavefront analysis are very dissimilar, the patient is not a good candidate for wavefront treatment. It is particularly important in irregular corneas, post-cataract and post-refractive surgery retreatment and high astigmatism. It also helps to plan custom ablation, aberration neutral treatment profile. Custom wavefront ablation generally removes more tissue than standard ablation in the same eye. This is an example of the preoperative worksheet in a LASIK patient. It should have AR values, K values, axial length, CCT, PG power, final refraction, pupil sizes, white to white, postoperative K values, cover test, anterior chamber depth and gonioscopy, specular microscopy, and Shermer. Coming to the most important part, that is the preoperative counseling. The patient should be explained that they can expect only the best spectacle corrected visual acuity. They should be explained that this will not alter the presbyopia or cataract that can happen in future. Procedure of monovision correction should be properly explained. Always assess the patient's expectations. Explain realistic goals along with rare chances of complications of treatment. A good candidate is one who, despite of expecting improved vision, would still be okay with the idea of having to wear glasses under certain situations, such as when driving at night. For more apprehensive patients, we can show them the recently published data on the safety and acceptability of the refractive surgery. Also, display your credentials prominently in your cabin for the patients to see. Involve parents and attenders in the counseling process, which helps to build trust and rapport. Always promise less and deliver more. So to conclude, careful patient selection and a well-planned treatment can always produce happy patients.